So my name is Murray Joseph Burbridge. My pleasure to welcome you all. Really excited to see so many folks out. And we're just really pleased and excited to have the opportunity to be having this discussion tonight. It's something that for many of us, those of us particularly living with HIV and those of us in communities where HIV has had such a profound impact over the decades, having this kind of a conversation that we're delving into tonight is something that we never would have imagined even a few years ago. So very pleased that you are going to be a part of it, that you're contributing for your own knowledge, but you're also going to be giving us some of your insight and knowledge, and we really appreciate that. I want to also do a quick thank you to the Ontario HIV Treatment Network for their support in making this possible tonight. Lots of support from them, from financially covering the expenses for the evening, as well as lots of staff time in preparing what you're going to see and the things that are going to unfold in the coming months. I am co-chair for the Toronto to Zero, or the Fast Track Cities initiative in Toronto, with Darian, whom you'll meet shortly. And I'm going to do briefly a couple of quick comments and another introduction, and then we'll get right into things. So as we begin the evening, I do want to kind of situate ourselves and acknowledge as a part of our ongoing efforts towards a deeper understanding and reconciliation, that we'd like to acknowledge the sacred land on which we're gathering tonight. It's been a site of human activity for 15,000 years. This land is the territory of the Huron-Wendat and Puton First Nations, the Seneca, the Mohawk, the Métis, and most recently the Mississaugas of the New Credit First Nation. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. Toronto was the meeting place, and today this meeting place of Toronto is still the home to many Indigenous people from Turtle Island, and we are grateful to have the opportunity to live, to work, to play in this community and on these traditional lands. I'm conscious that to make sure that I'm being respectful and accurate, that I'm reading words on paper, but that that my intention and the intention in those planning is that this is very authentic and important way to situate ourselves and continuing our thinking and understanding of this. And I'm pleased as a part of that to introduce Trevor Stratton, who's with us this evening and will share some greetings on behalf of the Mississaugas of the New Credit First Nation.
So I don't know if you realize that the Mississaugas of New Credit, all of the Mississaugas used to live along the north shore of Lake Huron up until about 1630. By the mid-1600s, French explorers learned about the Toronto Carrying Place. This was a portage route that began in Toronto that would go all the way up to Georgian Bay without going through all of the Great Lakes. And this became important later on, and I'll explain that a little bit. I'll be quick. In 1695, there was a peace treaty, and the Mississaugas decided to settle permanently on the southern shore. And that was as a result of the Dish with One Spoon Wampum Belt covenant that you mentioned. And the Ojibwe in 1700 had settled most of southern Ontario. The French opened up a credit trading post at the mouth of the Credit River and named Mississaugas of the River Credit Indian due to trade and credit practices with the First Nations people. And that's where you get this Credit River, Mississaugas of the Credit River. And when we moved, we became Mississaugas of the New Credit, in case you were wondering what the heck that weird name is all about. There was in 1787, there was a Toronto Purchase from the Mississaugas of the New Credit, which was found out to be illegal because the deed was completely blank. This shotgun treaty covered Mississauga lands and still to this day remains controversial. Mississaugas of the Credit were supplying the growing villages and towns around here with food and barter, and in 1787, that Toronto Purchase was ratified by the British government, and a mission settlement was established at the Credit River. That's the Christian mission settlement. By 1830, the Mississaugas were outnumbered 100 to 1. by non-Indigenous peoples. And meetings began to happen to discuss moving our community from the Credit River. Forced from the Credit River area, we moved to our present location near Hagersville, Ontario, right next to Six Nations of the Grand River. 1921, they built a one-room schoolhouse where my mom went to school with I don't know if you know Dr. Malcolm King. He was the director of the Aboriginal Peoples Research Institute. In 1987, we had our first Three Fires Homecoming Powwow, because you know our ceremonies were illegal for a long time. And when we had our first powwow, we had picketers from our community who were Christians saying, you know, drive the devil worshippers out. And we've come a long way since then. There was a Toronto purchase claim made by the Mississauga's Tribal Claim Council to address this blank deed from 200 years previously. And in 2010, the Government of Canada settled the claim with an offer of $145 million to our community, which we gladly accepted. And I talk about this in the spirit of truth and reconciliation and addressing the trust issues between Indigenous and non-Indigenous peoples, not only in North America, but all over the world, and the importance of the recommendations of the Truth and Reconciliation Commission. It's really heartwarming to see gatherings like this open with a traditional acknowledgement of the land, and it really does go a long way for Indigenous people and non-Indigenous people, because we need to have these discussions. Reconciliation is a conversation. It's not an end point. It's the beginning of something pretty special. So I thank you very much.
Thank you, Trevor. Appreciate your words. You will have three folks leading you through this evening up to when we can break into some discussions at your table. And I will be introducing Gareth, who's the host for walking through the next part of the evening. So Gareth is an LGBT and HIV activist who fled from Jamaica to Canada in 2008 because of persecution he faced due to his activism. He's the interim director of programs and services at Toronto People with AIDS Foundation. In addition, he works at Rainbow Railroad, supporting LGBT individuals fleeing state-sponsored homophobia and persecution. And he's featured in two of Canada's National Museum for his work, the Human Rights Museum in Winnipeg and the Refuge Canada exhibit at Pier 21 in Halifax. Gareth.
Good evening, everyone. You know what's funny is that I do so much public speaking, but then my first 2 minutes I tend to be nervous. Okay, so this first I want to say I'm really happy to see the turnout this evening, despite the weather. We're happy still it is not snowing, but it's good to see when community respond to a call, and it's a very important call. We are here this evening to have a dialogue, to have conversations, to hear from you as to our next steps around ending Toronto's HIV epidemic. And it starts with us. And the demonstration that you are here this evening, I believe that it fits perfectly well in this, that it starts with us. And if we all believe that, can we all say that as a collective? Okay, that was a test run. Let's go again. Yeah, and that's and that's what we want, and that's the energy, and that's why we're doing this consultation. So then your voices can be heard, and whatever decisions or strategies that have been developed, you can identify with that, and you can help to bring that message to someone who might not have been here, be able to spread that word around that we want to get Toronto to zero, and that is very important to us as a community. Part of the reason why we're all here. And so I just want to read something quickly that. The world is at a tipping point in stopping HIV. We have the knowledge and the tools we need to prevent new infections and improve care. To do this, it requires political will, resources, and community engagement. Again, why we're here this evening, it is important to us. Anything that is for community must represent, and community must have an opportunity to participate in these kind of strategies. We can't get to zero without all of us actively being involved and engaged on a regular and constant basis to create that kind of a change. Right, so with the logistics all the way, we're going to be doing a presentation. It's going to be about half an hour maximum, and then we want the chunk of the evening to be about us. We sitting and having conversations at our round tables, and the tables again are circular. Important is that we're all equal. Each voice at the table is valuable, is important. We want to hear from everyone, and everyone should feel comfortable in sharing their thoughts, and it is valued and will be acknowledged and appreciated. So to start us off, we're going to have Darren Taylor. And Darren has been living with HIV for about 30 years and has worked in the HIV field for the most of that time. She is a co-chair with Murray Jose of the Toronto Fast Track Initiative. So help me welcome Darren.
And thanks to everybody for showing up tonight. This is a great turnout. We didn't know, right? We were like, is anybody going to come? A few people? This is fantastic. It makes me really happy, and I'm really happy to be here. This is just so important to me. I was saying to somebody earlier in the facilitators meeting that, my crabby ghost won't haunt the halls of the 519 if we can just end in the epidemic before I die. So that should be impetus enough. Okay, so first of all, I want to start out by saying we're not talking about a cure for HIV here tonight. I know sometimes when we start talking about ending the epidemic, people think, oh my God, there's a cure for HIV. No, hold on. There may be, but that's not what we're talking about right here. There are many different ways that we could define this idea of the end of the epidemic. And I know that people with HIV sometimes feel a little bit leery about this idea of the end of the epidemic because they're like, hey, what about me? I'm still here. I'm still dealing with it. But regardless of how we define it, any definition of ending the epidemic is going to involve drastic declines in new infections in key populations. But it's not just about reducing new HIV infections. This is not just a big prevention initiative, although it is a big prevention initiative. Short of having a cure for HIV, what we have here now is an opportunity to improve the health outcomes amongst people who are currently living with HIV by ensuring their access to medications, by ensuring their access to care and their retention in care, by ensuring things that affect the determinants of health, like a living income, housing, and eradicating stigma. Early diagnosis and the early initiation of treatment is linked to good health outcomes for PHAs in the long term. The number of people with HIV in Toronto continues to increase because people are living longer thanks to the effectiveness of HIV treatment and the effectiveness of prevention and treatments of comorbidities associated with living with HIV. This is all good news. But the bad news, and we don't want to concentrate on the bad news tonight, so I'm going to say it and then it's all good news. The bad news is that the number of people who are infected, the number of people who are infected with HIV in Toronto continues to rise by about 2 people per day. If we are able to dramatically decrease the number of new infections, the number of people living with HIV will also start to decrease. At the same time, of course, we've got to continue to invest in the health of people living with HIV. So there's lots of reasons to believe that we can be successful in ending the HIV epidemic here in Toronto and ensuring that there are no new HIV transmissions and that there's equitable access throughout for the tools to HIV prevention and treatment. And that reason is our community's history of resistance and engagement. I see lots of people here that I've seen for years working in HIV. And We want to honor this work. We want to welcome the newcomers, of course, but we want to also honor the work of community and activism that has provided the foundation for our work here tonight. So unlike other global cities, Toronto is not yet seeing a reduction in the number of people diagnosed with HIV, in spite of the significant investments that have been made by all of us and by different levels of government over many years. So we need to sharpen our focus and set sharp goals and targets, measure our progress, and scale up some coordinated solutions. Right here in Toronto, we can use the framework of the Fast Track City Initiative, which was originally conceived of a couple of years ago by the UNAIDS as part of their global 90-90-90 campaign, which you may have heard about. So we can take the examples, the lessons learned from other cities that are already ahead of us as fast-track cities. We can learn from them, we can improve them, and we can make Toronto a world leader in ending the epidemic. So even though we're a little bit late to the party, we're going to clean up. So later in our presentation, we'll discuss some of the challenges and how we can close the gaps so that no one is left behind. I don't see this as a 90-90-90 strategy. I see it as 100-100-100 if everybody wants it. Some other reasons for optimism are that through research and the experience of other global cities who participated in this initiative, we know that there are three powerful tools that are now in our hands that will help us to end the HIV epidemic in Toronto. And that's the concept of U equals U, PrEP, and expanded testing. Thank you. So we now know that medications that treat HIV can also prevent HIV transmission, PrEP, in other words. So if you're HIV positive and you take HIV treatment and it suppresses your viral load to undetectable levels, you cannot pass on HIV to the people that you have sex with. In other words, undetectable HIV is sexually untransmissible. That's the key to U equals U. Yay! If you're, yeah, it's like fantastic, right? It's amazing. I mean, who thought, right? And if you're HIV negative, you can take a pill that's commonly used. You can take the pill that's commonly used for treating people with HIV. And in that situation, it's extremely rare for HIV to be transmitted to the people that you have sex with. Now, let me just acknowledge that there is lots of discussion about this undetectable, extremely rare, almost never, etc., etc. Lots of discussion, lots of controversy. I think that this initiative will help to solve some of that controversy, but I don't want tonight, if we can possibly help it, to get bogged down in the question of risk. So when we talk about U equals U, we're talking about the sexual transmission of HIV. If you have HIV and you're pregnant and you want to have a baby, HIV treatment can also help you to have a healthy HIV negative baby. However, because there's been limited research on women on HIV treatment who are breastfeeding or chest feeding, Canadian guidelines currently recommend that you should feed your baby exclusively formula. Now, we have been doing a lot of thinking in preparation for this meeting about where we come down around U equals U, where we come down about transmission in ways that are not sexual transmission. I mean, if you want to, we can talk about that perhaps at the end of this event. All of this stuff is very much in the air right now. But I mean, I do have some thoughts about that we've prepared about HIV transmission and what U equals U means to women. But I'm going to wait to see if that is an issue that you want to speak about. The other thing that I'd just like to alert you to is also the research about people who use injection drugs. So research suggests that if you are an injection drug user and you have an undetectable viral load, that can also help in the prevention of transmission between people who inject drugs. But again, not yet enough evidence to prove that there is no risk of transmission. So there's these question mark areas around transmission, but all of these strategies are definitely aimed at risk reduction and definitely part of what we see as the strategy for Fast Track Cities. I am now going to hand the mic over to John McCullough. And first I'm going to introduce you to him because you need to know this man. He's been incredibly inspiring around the U equals U message. And I think one of the reasons that we're all here today. John has worked with people living with and at risk of AIDS since the beginning of the epidemic. More recently, he's brought his lived experience to improving the lives of adults who are aging with HIV. He's currently the chair of the board at CATIE. He's the co-chair of the Ontario AIDS Network. And his focus is on ending the epidemic of new HIV infections and improving health outcomes for people living with HIV. In that respect, he's a member of the champions team of the Toronto to Zero initiative. You're going to hear these two terms, Toronto to Zero and Fast Track Initiative. They're interchangeable. It's just that we've only just named the initiative Toronto to Zero. So a lot of us are still saying Fast Track City. But you're going to be saying Toronto to Zero a lot over the next few years. And John is also one of the people who's been instrumental, as I said, in bringing the U equals U message to Canadians. So he's going to take us through the concept of U equals U a little bit more, the research behind it, plus talk to us about some other things that can reduce the risk of HIV transmission, including PrEP and testing. Thank you.
Thanks, Darren, very much. I'm actually just an ordinary gay guy who's lived here in the city for a long time. So I feel very humbled by hearing me described in that way. Like many of you in this room, I have been, like many of you in this room, I've been around Toronto since the beginning of the epidemic. And of course, I have experienced that trauma and that awful history of seeing my friends die, of wondering whether it would be my turn next. And that memory, I think, for many of us remains traumatic to this day. But also in the last 3 decades and a half, I've been also witness to two remarkable developments that have really changed HIV from what it was in those early days. So the first one was 22 years ago in Vancouver, where community members and researchers announced that if you take a combination of 3 antiretroviral medications, you could stay alive and hopefully live a healthy life. And we saw people actually literally rising from their beds when they took that medication. Those early meds were difficult to take. There were many of them. There were all kinds of rules around when you can take them. And they had a lot of side effects, some of which last to this day. But they did keep people alive. The medications we have today are much easier to tolerate for most of us. with little or no side effects for most of us. And I personally take 1 pill a day. It looks like a multivitamin, and that's all I have to do. So that was great news. But what we've seen particularly over the last 10 years is increasing research that's telling us that maybe antiretroviral medication to treat HIV also prevents HIV from being transmitted. And this research has taken place slowly over the last 10 years. And at first it was highly controversial, and people were really unbelieving and actually ridiculing the people who were saying these things. But we have developed this, and so we've reached the stage that is on the screen. I'm going to talk about it in a moment. But I just want to mention one piece of research that I think is really key, and it's called the PARTNER study. And it involved 8 European countries, I think, and 500 heterosexual serodifferent couples, by which I mean one partner is HIV positive and one partner is HIV negative. And it also involved almost 1,000 gay male serodifferent couples as well. And this research was done over 8 years, from 2010 to 2018. And amongst the women, amongst the heterosexual couples, and these are all couples who, by the way, who were not using condoms. This was not a study that was a randomized control trial where you said, well, you use a condom and you don't, because that would not be ethical. These were people who had chosen not to use condoms, and for many of them had been not using condoms for many years. And they, amongst the heterosexual serodifferent couples, there were 36,000 sex acts of condom sex, and not one transmission of HIV occurred between the positive and the negative partner. Likewise, in the gay male cohort, which was almost 1,000 guys, there were 77,000 condomless sex acts, and not one infection was passed. And that really leads me to this. It's now very, very clear that the risk is zero. If you're on suppressive antiretroviral treatment, you're sexually non-infectious. Undetectable equals untransmittable. Well, we've known that for the last couple of years for sure, but this was at the International AIDS Conference in Amsterdam, which I know many of us in the room attended. And the big conference room in this conference center in Amsterdam was probably the size of 2 football fields, just exploded with applause. It was a very, very moving moment. If we can go on to the next slide. So this is really a powerful prevention tool. But what I'd like to say just about this slide here, that if you're diagnosed early, you start treatment promptly, you can live a long and healthy life, you can have HIV-negative children, and you can't pass on HIV to your sexual partners. That really is the message. It's not just about not being able to pass on HIV, it's all those positive things as well. And when you compare that message to the message that most of us have heard throughout the life of the epidemic, is that if you're living with HIV, you're basically carrying some dangerous virus that could damage other people, and that the public had to be protected from you. And now this has totally changed how we think about life with HIV. It's really difficult as somebody living with HIV let me say to you that to overstate the power of that message. And it kind of opens up to us choices we never thought we'd have possible for social, sexual, and reproductive lives. It encourages us to start and stay on treatment for our own health and that of our partners. And it opens up kind of opportunities to change the way not only we see ourselves, dealing with that kind of self-stigma, but also how others perceive us, our loved ones, our family, our friends, our current and potential sexual partners. So I'm actually thinking that now we should always start any conversation about HIV with not risk talk, but with that one, that if you have HIV and you start treatment early, you can live a long and healthy life, have HIV-negative children, and can't pass on HIV to your sexual partners. But it's doing what? So that last slide was really how it speaks to people living with HIV, but really what it does for the broader community is that it really undoes that 35 years of previous messaging that saw people like me as vectors of disease from whom the public had to be protected. So what you can do is actually that message can be of what HIV means today can be heard by the broader community, and hopefully as a result of that, some of the stigma and the fear can be lessened. The other good thing about it is it motivates testing. I know I hear stories quite a lot of people who don't take an HIV test because they're terrified of the result. And they'd rather not know, and that's a very human kind of response. But really, if I'm not downplaying an HIV diagnosis, but I mean, if you are getting a test, it's much better that you know, because you can go on treatment right away and you can do all those good things from the previous slide. It also motivates us to start on treatment early. It motivates us to improve adherence to our medication. And I think it's the best tool we have to really dismantle stigma. And it allows us really to imagine a community where there's no distinction between those of us who are HIV positive and those of us who are HIV negative. It's really a message of celebration and hope. So some of you may be saying, well, that's all very nice for you, John. You're very lucky to have an undetectable viral load. I don't, and I feel kind of second class, so I feel stigmatized. And that's a very legitimate concern and a very legitimate issue. And I just want to address that we must be very clear that we cannot, and we do not, and we must not create two classes of people living with HIV, people who are living, who have an undetectable viral load, and those who have a detectable viral load. Because we, as people living with HIV, are more than our labs of results. We're more than our viral loads. And the reasons that some people don't have undetectable viral loads is all tied into treatment, to their choice. Everybody has a choice whether or not to go on treatment. Some people will go on treatment and may have some challenges around reaching an undetectable viral load. And there are any number of reasons that people, because they have so many other issues in their lives, that can really make it difficult for them to achieve undetectability. So nobody should be shamed for not being on treatment or for having any level of viral load, whether that's their personal choice or whether it's due to circumstances beyond their control. People living with HIV, whether they're detectable or undetectable, are not a danger to others, and everybody, whether they're detectable or undetectable, have a right to full social and sexual lives. One final thing I'd like to say, though, about this is that because the benefits of being undetectable are so amazing, this is really, UKSU is really a new tool for advocacy, because those compelling benefits make us, like we can argue that this is cost effective, that this helps people live long and happy lives, that treatment is not like it used to be, and it allows us really to use this as an advocacy tool. So I think what I've tried to say here is that UKSU is much more than you can't pass it on, although it is that too. So I'm going to move on now to PrEP, or pre-exposure prophylaxis. And for those of you who may not be aware, PrEP is a the same pill that somebody like me takes for treatment can also be used by somebody who's HIV negative but feels they're at high risk for HIV to prevent the transmission of HIV. It's like 99% effective. We've actually come a long way, I think, in the last 2 or 3 years since PrEP was approved in Canada. I remember, maybe many of you do too, and this was particularly true in the gay community, that guys who took PrEP were slut-shamed. They were called Truvada whores, Truvada being the brand name of the medication. But it's quite remarkable to me how in that short period of time, the concept of PrEP has moved from being somebody who just wants lots of sex without condoms to really a responsible person who is taking care not only of their health, but the health of their partners too. And the other very moving thing I think that I've heard from guys, particularly, forgive me if I speak of guys, I mean, PrEP is available for everybody, but I can only reflect my own experience as a gay man. But the number of times I've heard people say, for the first time in my life, I've had sex without fear. I mean, that is just so amazing to me. And these guys are feeling that, and I'm sure the women who've taken it too can feel that now I actually don't have to, every time I have sex, I don't have to have this worry in the back of my mind. Now, there are some things about access to PrEP. PrEP is, it's not free in Ontario. There are generic versions which are cheaper than the brand name version now. Private insurance will cover it. Those people who are on Ontario drug benefits can cover it, can get coverage. But in fact, for other people, it's not always so easy. And the other barrier, I think, is that a lot of physicians have a lack of knowledge about PrEP, and they find it difficult. They really don't. They worry about prescribing it, and sometimes those of us, or those people who might want PrEP, really don't want to talk to their doctor about this. So that's very problematic. But one of the good things now is that in Toronto, I think there are at least 2 PrEP clinics where you can just walk in and talk to a medical professional about getting on PrEP if you feel that's for you. One is at the Maple Leaf Medical Clinic, just across the street at College and Young, and I believe the Toronto General Hospital Immunodeficiency Clinic also offers a similar program. One other thing I just want to do before I move on from both PrEP and U is to say that neither of them are about sex without condoms. You can have sex without condoms, but it's not about sex without condoms. Condoms are still important. I don't want to underplay that, but it's not necessarily about any kind of sex. It's just about how this makes you feel, knowing that you have control over your own life. You have agency. So my last slide is about testing. Now, this is not, unlike you and PrEP, this is not a new technology, but there are all kinds of new ways that the testing is now offered. But testing is the foundation to ending the epidemic, because really, if you don't know you have HIV, you can't get treatment. And so we really do have to dramatically increase our testing efforts to reach the undiagnosed. Now, unfortunately, we don't know in Toronto how many people living with HIV are undiagnosed, but across Canada, the latest estimate from the Public Health Agency is, I think it's 14% of all people living with HIV have HIV and they don't know it, either because they've never had a test or they've been infected since their last test. And those people could have a very high viral load, and you know, if they're undiagnosed, then they likely are passing on HIV to other people too. So if we can increase our efforts to reach the undiagnosed, we will dramatically reduce the rate of infections. The other thing is frequent testing. It's not necessary. It depends how sexually active you are and what kind of relationship you have. But if you have lots of sex and you only get tested once a year, that really probably isn't quite enough. So we need to promote frequent testing as a responsible choice for our own health and that of the community, because it reduces the community viral load. But testing has to be responsive to individual need. It needs to be culturally safe. It needs to be sex positive. And so we really need to make sure that where testing is done, that is done in a way that makes us feel comfortable. And I'm fond of saying that what we should be doing more of is bringing the test to the people rather than the people to the test. What I mean that is, right now you have to go to a sexual health clinic or your doctor's office and ask for a test. It's much better, I think, if we bring the test to a place like the 519, where there are people like all of us who have been trained and are testing our peers, and that makes a level of comfort. I think that makes testing much more accessible. There's also new testing technologies. We can now have a rapid test where you can get tested and get the result right away in 15 minutes or so, as opposed to a blood draw in a clinic, which is you've got to wait 2 weeks for your answer. There are also tests now that you can do more than one test at once. Syphilis and hepatitis C can, in theory, be tested together, although those tests haven't come to Canada yet. They're called multiplex testing. There's also another new technology called a dry blood spot test, where you basically get a finger prick and you put your finger on a piece of filter paper, and that's taken away to be examined, and that's a very easy way to be tested. And just finally, I want to say home testing is something that is available in the States. It's not available. It's available in the United Kingdom. It's not yet available in Canada. But I've been privileged, along with some other people in this room, to be part of a group of researchers and clinicians and community people who are working very hard to ensure that all the modern technology that we now have comes to all Canadians wherever we live. And also for home testing. And I am very optimistic that these things will happen before long. So that's all I want to say at the moment. So I'm going to pass it now back to Gareth.
So Toronto to Zero means that we have a lot of work to do as a community. And so if we can't get there unless we do things. And one of the important things is for us in terms of getting to zero is that how do we improve the lives of people living with HIV? It's very important. It's something, it's how do we help an individual or a PHA walk out of that shadow? And stigma, I would say no more stigma. Stigma is a crippling kind of effect. It impacts people in very different ways. And if we're able to get community persons, PHAs to feel more comfortable within even within this space, to be able to talk about the HIV and feeling not that they'll be judged or be treated differently, it's a huge and significant start. And stigma still do exist, and a lot of PHAs struggle and wrestle within that shadow of darkness. And a part of getting to zero means that how do we as community help our brothers and sisters to get beyond that? Because in building and creating, we talk about safe and affordable housing, we talk about safe and supportive communities. But the harsh reality of it is that a community can never be truly safe unless all members of the community is safe. And as a community here this evening, we have a kind of a moral obligation. If we want to feel that true sense of safety and that we are contributing to getting to zero, is that we, as it is, how do we become our brother's keeper and be active in what needs to be done and creating some kind of a social change? Ending epidemic is not about protecting HIV negative people from HIV transmission. It's about improving health and well-being of all people living with HIV. And I think Toronto can make a significant difference in becoming, from other fast-track cities, by becoming a leader in how we support and proactively engage and support PHAs. These essential services are critical to ensuring that people living with HIV have their basic needs met so that they can dream, plan, and live the lives that they want to live. And, it's no one left behind. With all the access, that we have in the city, there are still a lot of folks who fall through the cracks. There are a lot of PHAs who fall through the cracks who don't have access. And it's how, so if we're going to get to zero, is that it means it's all of us. How do we reach those hard-to-reach PHAs who oftentimes can't access services, who can't even access mental health services because, guess what? It's a very long and exhaustive kind of a wait list. Is how do we make sure that everyone have access to treatment and everyone have access to the needed support that they do need. We know the homeless population, the size of the homeless population here in Toronto. A part of, in terms of, no one being left behind is how do we engage with our political leaders? How do we engage with our MPP in creating opportunities for persons to be able to have the basic necessities of life, which I think, all these things are basic human rights that some people who are falling through the cracks are not being afforded opportunities to do so. It's our collective celebration of you equal you is undermined because of our access to HIV testing, treatment, care, and support is unequal and inequitable. And it's a piece around social justice and structural barriers. Oftentimes we come across so many red tapes, so many differences in terms of opinions and thought processes. But for any plan to end the HIV epidemic to succeed, we must maximize the number of people accessing effective prevention, treatment, and care, and address barriers that prevent people from living long, healthy lives. A person facing significant barriers to services is less likely to be successful at preventing new infection or reaching viral load suppression. Addressing the social determinants of health by improving outcomes related to income, housing, transportation, food insecurity, childcare, incarceration, trauma and abuse, education, and stigma, for example, is crucial to improving the lives of people living with and at risk of HIV and ending the epidemic. Yeah, and so, and I think I touched on this a little bit before, is that, HIV, the piece around challenging stigma. HIV continues to be a very stigmatized condition. And all of us in this room who might be living with HIV or affected by HIV or work within the sector do know how serious this is and how many PHAs on a daily basis, suffer from the fact that they can't feel comfortable going again, even within the medical fraternity, and the list goes on where people still. It's hard. It's a thing for me as an immigrant. Coming from a place of oppression, when I get here and realizing that the fear that PHAs live under, as someone who been living with HIV for over 15 years, it's hard. It's who do you tell? How will my family or how will community, how will my employer respond? Or how will the family doctor respond? Because the family doctor is not necessarily a HIV specialist. So we do have family members, persons who still fall within that shadow of fear, not wanting to come out and not able to access services. If they're not accessing services, it means then we won't be able to get to zero, and it means that we here in this space, in this time, have a responsibility and have a role to play in creating, in challenging stigma and eradicating stigma in all its forms and shapes. Next slide. So it is up to us. That's what tonight is all about, is that it is up to us to do our part in getting to zero. And, tonight there will be some facilitators at tables having conversations. So let me just see the hands of the facilitators at all tables, if there's it right now. Just making sure that there are facilitators at every table. Okay, so there are two, okay, I see you, Rodney. So I guess we need to address this table right here. And right here. Okay, great. So the facilitators, note takers at the table, we want to have some vibrant conversations. Please, share your thoughts, because I think we're all passionate about this. We're all concerned and we all want to see that we stop Toronto getting to zero as soon as possible. Okay. So I guess we will now run off into our meaningful conversation and dialogue.